Module 4, Teamwork and Communication. The Teamwork and Communication module of this AHRQ Toolkit will discuss how safety teams in nursing homes can understand and practice successful teamwork and effective communication to improve the resident safety culture in their facility. In this module, we will describe effective communication and teamwork, describe why teamwork training and improved communication optimize resident safety, list barriers, tools, and strategies to effective teamwork and communication, describe selected teamwork and communication tools, and review solutions to teamwork and communication challenges. Positive, two-way communication promotes teamwork and improves resident safety culture. According to an article in the Journal of Sociological Research, quote, "The more who feel they are asked for their input in doing their jobs and are told what they need to know to successfully do their jobs, the more likely staff members will be inclined to help others in doing their jobs as well as receive help from others. When these qualities of work are realized, stress is felt as less excessive. The more satisfied the long-term care workforce, the higher quality of care that is delivered to the patients." Because improved teamwork and communication is proven to increase resident safety, investing in teamwork training for nursing home staff is important. The most critical teamwork competency is effective communication. Team members must be taught to value teamwork and the trusting relationship on which it is based. They must know and be able to use effective strategies to enhance communication. When critical information is being exchanged, for example during a transition in resident care, the importance of communication becomes apparent. When a patient is being transferred from the hospital to a nursing home or during a change of shift report, vital pieces of information can be omitted, placing the resident at risk for an error in their care. In 2002, a Joint Commission report on medical errors stated that 70% of these errors resulted from breakdowns in communication. Communication is a process by which information is exchanged between individuals, departments, or organizations. What is effective communication? Communication is effective when a message is received, understood as intended, shared at the appropriate time to support the safest care for the resident. Why is effective communication among staff important? When critically important information is not effectively communicated, the results can lead to mistakes and potential resident harm. An example is if a staff member caring for a resident noticed some subtle changes in their health status but did not document this information or share it verbally with their team or the oncoming staff at shift change. These subtle changes may represent the beginning signs of an infection, like a catheter-associated urinary tract infection or CAUTI. Effective communication could have helped identify a diagnosis and treatment earlier and decreased harm to the resident. When staff, residents, and family members have mastered effective communication, everyone on the team feels they are contributing to the care of the resident. Compare this with the scenario of ineffective communication that could result in a medication error or other mistake that can cause real harm to the resident. In this scenario, the resident and family suffer and may lose trust in their caregivers, and staff may experience stress as a result of the impact of ineffective communication. Let's watch a demonstration of effective communication between a certified nursing assistant and a facility nurse.
Lisa, do you have a minute? I need to speak with you about Miss Matthews in room 355. Her daughter is really upset.
Really? Mrs. Matthews' daughter, Kathy, is always so friendly to everyone. What's the problem?
She was almost crying. She's worried about her mother's incontinence and the smell in her room when she arrived for her visit today. She asked if her mother could have a urinary catheter. I told her I'd talk to you about it.
Well, we don't put catheters in residents unless we have a valid medical reason, and urinary incontinence isn't one of them. I'll be down in just a minute to talk with her.
Okay.
Have you heard of the TeamSTEPPS program? It's an education program that teaches communication skills for teams. The program was first used in the military and was then used successfully in many healthcare environments. The following table from the TeamSTEPPS long-term care program highlights barriers to communication and the communication tools and strategies that teams can use to improve outcomes. We will review a number of these tools and strategies in detail in the coming slides. Examples that have been shared by other long-term care facilities include institutional barriers to communication, understaffing, a culture in which speaking up is not supported, staff turnover, inadequate teamwork and communication training, verbal abuse, fatigue, heavy workloads, and ambiguous instructions. Other barriers to effective communication may involve a lack of resident safety culture in the facility. Facilities that promote a culture committed to resident safety encourage staff to speak up if they become aware of a safety concern and create an environment in which staff feel comfortable and safe to communicate resident safety concerns. A culture of safety fosters trust that team members will respectfully listen and respond appropriately to the information they share. The TeamSTEPPS program for long-term care teaches the following tools to help healthcare teams improve their communication with one another: Brief, Huddle, Debrief, S-Bar, Cuss, and Desk. We will briefly describe each of these communication tools in the following slides. The brief is a short meeting during which all staff caring for a resident can discuss concerns, issues, or expectations of the day and then make specific plans to address the concerns, issues, and expectations. A brief usually occurs at the beginning of the shift and is designed to help all team members develop a shared understanding about the resident's plan of care for the day. This shared understanding creates a sense of teamwork and collaboration and provides an opportunity for team members to speak up if they have concerns. For example, they might discuss the resident's decreasing mobility and the risk for falls. The team could then make a plan to keep the resident from falling by providing a walker and teaching the resident to use the walker safely, or explaining to the resident when to contact the staff for help with getting out of bed. The brief ensures everyone understands the resident's needs and expectations, helps the team avoid surprises that could affect the resident's care, provides an opportunity for every team member to participate, and sets the tone for the day. Let's watch this short video depicting how a brief is conducted.
Hi everyone. Today we are at full census with no admissions or discharges expected. Mr. Vega's family will be bringing him to the doctor at 11:30. He'll need a bagged lunch. Alicia, can you call the kitchen and ask for one? Thanks. On the 24-hour report, it was noted that Mrs. Smith was up for most of the night. We'll have to watch her and encourage rest periods.
At handoff this morning, I was told Mrs. Smith was confused last night and was found wandering in another resident's room looking for her bed. I checked on her just now and she's still sleeping, so I didn't wake her.
Let her sleep. Her confusion and wandering is new, so I wonder if she might have an infection brewing. Let's encourage fluids just in case. Okay, now Mr. Steinberg.
Huddles are short, ad hoc meetings between two or more team members designed to ensure everyone who needs to know is aware of the current situation and is part of a shared response to the situation. A huddle is used in cases where the conditions for the resident, staff, or facility have changed since the last time the team met. A huddle allows a team to assess the impact of the change on the team's ability to perform duties and to adjust plans as needed to be sure all duties can be performed. Let's say a resident becomes acutely ill and needs one-on-one care in preparation for transfer to a hospital. Staff members caring for that resident should be assigned fewer residents, which means another team member must care for those residents. A huddle allows the team to quickly meet to discuss the situation, its effect on workload, and the necessary reassignments. It allows information to be shared with everyone involved, explains why assignments are being changed, and alerts staff to the safety needs of the unstable resident. Another example of the use of a huddle is the morning safety huddle, where a leader, such as a charge nurse, calls the team together to discuss the safety needs the staff have identified for their assigned residents. This can include a review of residents with an indwelling urinary catheter, the approved indication for the catheter, and the continued need for it. Let's watch this short video depicting how a huddle is conducted.
Lucy, how's Mrs. Smith doing?
Yeah, I wanted to talk to you about her. I've been offering her drinks all morning, but she doesn't want them, and she only ate about 25% of her breakfast, which was weird because pancakes are her favorite. She also seems to be coughing a bit. She definitely isn't herself today.
I agree. Can you go take her vitals? I'll be right in to assess her.
A debrief is an informal but structured discussion of an event after it occurs. The debrief meeting is ideally conducted with all team members that were involved in the event. The discussion is focused only on teamwork issues and is designed to improve performance and effectiveness. A debrief is a good time to reinforce positive behaviors demonstrated by the team. The team's discussion during a debrief can be facilitated by using a checklist using the following questions as a guide. Was communication clear? Roles and responsibilities understood? Situation awareness maintained? Workload distribution equitable? Task assistance requested or offered? Errors made or avoided? Availability of resources adequate? Could what went well be changed or improved? Let's watch an example of a debrief used by a team at a long-term care facility. Pay attention to the questions the team addresses.
Well, last week we learned about debriefs at our TeamSTEPPS training. Let's talk about how that conversation went. What do you think went well?
Ms. Matthews was comfortable enough to speak up. She shared her concerns with all of us.
I agree, Alexa, and thanks for bringing Ms. Matthews' concerns to me. If we weren't all working together to solve this issue, it could have caused her to become frustrated with everyone caring for her mother.
Lisa's right. Alexa, thanks for bringing Ms. Matthews' concerns forward. So, any other thoughts on what went well?
I thought we made her feel welcome and like a member of the team caring for her mom. And I thought you set a good tone for the meeting, Barry.
Well, thanks, Lisa. I agree. It felt like a comfortable conversation. So, what did we learn?
I learned a lot about Ms. Matthews' concerns related to her mom's sense of dignity.
I think that we also learned when we explain things clearly, people understand why we do what we do. Once we explain the risks associated with using catheters or possibly using antibiotics, Ms. Matthews actually agreed that those were things we all wanted to avoid.
I think Ms. Matthews thought a catheter would be an easy answer, but it sure can create a lot of potential problems.
So what can we do differently next time to make conversations with residents' family members even better?
I think that Ms. Matthews was pretty brave to come by herself and talk with us. We should have mentioned that she could bring somebody with her. I think that we should offer families the option of bringing more than one family member to join these types of discussions.
I think it'd be great to include the resident, at least for part of the meeting, to find out what she prefers.
That's a great idea, Alexa, although it depends on the cognitive function of the resident. I think we had a productive discussion with Ms. Matthews today. But we also need to be thinking about preventing resident issues that cause family distress in the future.
I think there are other residents who have the same problem Mrs. Matthews does.
I agree. How about I work with the nurses to identify other residents who could benefit from a toileting schedule?
That sounds like a plan. Let's talk about it at our joint staff meeting next week. Thank you, both of you.
Has anyone here ever heard of S-bar? Anyone used it before? The S-bar technique provides a standardized way for team members to concisely communicate about a resident's condition. Standards of communication are essential for developing teamwork and a culture of resident safety. S-bar is an easy-to-remember way to frame any conversation, especially a critical one that requires immediate attention and action. It provides team members with an easy and focused way to set expectations for what will be communicated and how. In phrasing a conversation with another member of the team, consider the following. Situation: what is happening with the resident? Background: what is the clinical background? Assessment: what do I think the problem is? And recommendation: what would I recommend? SBAR provides a vehicle for individuals to speak up and express concern in a concise manner in both clinical and non-clinical settings and departments. Let's review how to properly use SBAR. In this video, the resident's condition has worsened, resulting in a telephone call to the attending physician. Watch the video to see the transfer of information using SBAR.
Hi, Dr. Flores. This is Liz James from the Shady Pines Care Center. I'm calling you about Mrs. Mary Smith, 88 years old, has had a change in her condition. She has a new onset of confusion, has developed a cough, and she didn't eat much today. 25% of breakfast, 50% of lunch, 75% of dinner, and she's not taking on any extra fluids. Mrs. Smith has type 2 diabetes, arthritis, osteoporosis, cataracts, stress incontinence, and mild cognitive impairment. She walks with a 4-point cane and is hard of hearing. She is lethargic but responsive to simple verbal commands. She doesn't normally exhibit impaired judgment, but last night was found wandering in other residents' rooms looking for her bed. Her blood sugars and vitals are normal. However, she has been running a temp of 99 since 11 this morning. She has a dry cough, and on auscultation of her lungs, she has some rhonchi in the right base, and her urine looked cloudy. I am wondering if she's starting with a UTI or respiratory infection. I think she's stable to stay here with us, but should we get a urine, chest x-ray, or other lab work?
Handoffs occur during a change in assignment for the responsibility of caring for a resident. A handoff may occur when a resident is first welcomed to the nursing home from the hospital or during a shift change. When a resident's care is turned over to another staff member, even for a short time span such as a lunch break, a structured communication should occur to provide the oncoming staff member essential information about the resident. This important communication process increases resident safety by preventing the omission of important details about the resident's needs. Sometimes staff use a handoff form to effectively and efficiently convey the needed information. Remember, a handoff can also be used in non-clinical settings and departments. I pass the baton is one option for structured handoffs during transitions of care. Each of the elements are briefly described. I. Introduction. Introduce yourself and your role or job. Include the resident. P. Patient or resident. Provide their name, identifiers, age, sex, and location. A. Assessment. Describe relevant diagnosis and complaints, vital signs, and symptoms. S. Situation. Describe their current status, such as active daily living status, their intake or appetite, elimination, behavior, cognition, including code status, their level of uncertainty, recent changes, and response to treatment. S. Safety concerns. Provide critical lab values or reports, allergies, alerts, falls, isolation, etc. The B. Background. Provide other diagnoses, previous episodes, current medications, and history. A. Actions. What actions were taken or are required? Provide a brief rationale for each action. T. Timing. Describe the level of urgency and explicit timing and prioritization of actions. O. Ownership. Who is responsible? Nurse, doctor, APRN, or nursing assistant? Include the resident or family responsibilities for care. N. Next. What will happen next? Anticipated changes. What's the plan? Are there contingency plans? Let's review how to properly use I pass the baton. In this video, the nurse is providing a shift change report for an unstable resident.
Good morning, Gail.
Hi, Liz. How are you?
I'm glad to see you. I worked a double. But the good thing is I've been on the same unit, so I can update you on Mrs. Smith.
Oh, good.
You know Mrs. Mary Smith in room 152, bed 2?
Yes.
She has a low-grade fever of 99. Her urine was reported cloudy, and her cough remains dry, but she has some rhonchi in her lower right lung. Her vitals and blood sugars are normal. She ate better at dinner, and she is taking on some extra fluids.
Good.
Dr. Flores ordered a chest x-ray and a series of labs for her. She's on acetaminophen, PRN for pain, or for fever greater than 100. We're just awaiting her lab results. They should be here by 11 a.m. Her increased confusion was beyond her normal cognitive impairment, so we thought she might have an infection. However, besides the acetaminophen, there's been no changes in her medication so far.
Okay.
We are encouraging fluids and have her on I&O for the next 72 hours. She seems to like popsicles the best. Dr. Flores will be here this afternoon to examine her. However, if there are any changes at all, call him immediately, or if there's anything outstanding on the lab report. Also, Mrs. Smith's daughter, Diane, has been notified, and her care plan and CNA assignment have been updated.
Another way to effectively communicate among all team members is to use structured language. Structured language uses key words as red flags to prompt team members that something important is being said and that all team members should pay attention. This type of communication can also be used to increase the speed at which information is shared. It is important that both the sender and the receiver understand the words that are used during structured language communication. CUS is one type of structured language. How many of you have had the experience of telling someone something important, but you believe they may not hear you because they are busy or distracted by other tasks or people while you're trying to convey an important message? CUS is one method that can be used to be sure your message is heard. CUS stands for the 3 words, concerned, I am concerned; uncomfortable, I am uncomfortable; safety, this is a safety issue. When staff are trained to use the CUS tool, they become conditioned to listen when they hear these 3 key words. CUS can be used as one way to stop the line when something unsafe is about to happen to a resident. Let's watch this short video depicting how to use CUS.
Sandy, Mr. Larkin doesn't look so good. He seems weaker today. I just checked his chart, and he's not keeping up the same speeds as usual. And he's breathing harder, even at the slower pace.
Okay, I'll get to him as soon as I'm finished with Mrs. Adams.
Sandy, I'm concerned. I'm uncomfortable with how hard he's breathing. I think this could be a safety issue. I don't want him to pass out and get hurt.
Okay, I'll check on him now.
DESK is another structured communication tool that has the following components. Describe what is happening. Express what you are concerned about. Suggest other actions and agreement. And consequences described are stated in terms of impact on your team's goals. Let's watch this short video depicting how to use DESK.
Hey, Carmen.
What's up?
I want to talk with you about earlier. I sensed that you were upset with me for expressing my concerns about Mrs. Smith. I wasn't questioning your nursing ability. However, when you ignore my input, it makes me feel as if you don't value my opinion as a member of the care team. I wanted to be sure I communicated my concerns about Mrs. Smith's condition. If you have concerns about my observations, I would appreciate you taking the time to listen first. I'm not a certified caregiver, but I do observe the residents, and my perspective and interaction with them allows me to pick up on changes in their health, too. If you could acknowledge my observations in the future, I'd feel as if I'm a contributing member of the care team.
You're right, Jen. I should have listened to you earlier. This new assignment overwhelmed me, and I took it out on you. We're all a team, and I will take your concerns seriously next time.
Next, we will discuss some specific communication strategies you may want to use when communicating with residents and family members. Excellent communications with residents and their families can positively affect resident outcomes, perceptions of quality, and resident safety. One important example of effective communication in nursing homes is when staff actively engage residents and their family in developing a plan of care. When staff involve residents and families in the resident's care planning, the resident is more likely to experience higher levels of satisfaction and also follow their care plan. All of these actions improve relationships and increase teamwork, which can lead to improved clinical outcomes and quality of life for residents and their family members. Effective communication between staff and residents and family starts with providing complete, clear, brief, and timely communication. To effectively communicate with residents and their family, staff need to use non-medical, easily understood words in the language the resident and family members understand best. There are many ways staff can make sure residents and their family understand what is being communicated, including teach-back. Teach-back is a method of providing education in small steps and stopping to ask the listener to repeat what was heard. This allows the staff member to assess comprehension of the content provided. The staff member can clarify any questions the resident or family may have and repeat the most important points. If there is critical information for the resident and family to understand, it is best to provide the information in written form using the language they can best read, or use whatever communication method that works and is most effective for the resident and their family. The following video shows a facility nurse and a certified nurse's assistant engaging a family member in conversation around the family member's concerns.
Hi, Miss Matthews. I'm Lisa Cranford, one of the nurses who cares for your mother.
Yes, I remember you.
It's good to see you again. Alexa mentioned that you had some concerns. Why don't we step over here while your mother's resting?
When I first walked into her room, it smelled terrible. It just makes me so upset.
I completely understand. We've cleaned your mother and she no longer has an odor.
I don't want this to happen again. With her dementia, she doesn't remember to use the toilet. I want you to put in a catheter.
Well, Miss Matthews, we don't use catheters unless they're medically necessary, and urinary incontinence alone doesn't fit the criteria.
What do you mean not medically necessary? She's wetting herself.
I can understand that you're upset, and you're raising an important concern. How about if we work together with our nurse manager, Barry Woodman, on this? We can all sit down and discuss what to do together. How does that sound?
That sounds good. I like the services this nursing home provides, but this is just so upsetting. Mother would be so embarrassed if she could understand what was happening.
Let me contact Barry and see when he's available to meet with us, okay?
Communication between staff and residents and their family members is challenging for many reasons, some of which are listed on this slide. It is important for the safety team to identify and address these challenges to prevent any breakdown in information sharing and understanding. There are also barriers to speaking up that many staff and residents and family have noted. Fear is cited as the main reason people fail to speak up when they should. These fears can include the fear of feeling embarrassed or being ridiculed or being wrong. Many of these fears can be eliminated by simply inviting and encouraging every team member to speak up. Thanking those who do speak up can also reinforce that speaking up to improve resident safety is the new expectation. Families should also be encouraged to speak up and to be a partner in the resident's care. You can demonstrate support for family as partners by inviting them to join rounds or to be part of the decision-making discussions with physicians and staff. Encouraging the residents and family to ask questions and offering positive reinforcement when they do will ensure that they will continue to be engaged and not afraid to ask questions or provide input. Communication following an adverse event can be especially challenging. An event is an injury to a resident that is caused by a medical intervention rather than by the underlying disease or condition of the resident. Each facility has policies and procedures to follow after an adverse event occurs, and most involve working with a risk management professional. These procedures should minimally include the care providers following these steps. Provide care. Caring for the resident's physical needs after an event is the first step a provider must take. Report. Providers report the incident to the unit manager, resident's medical care provider, and the risk management department according to the facility's incident reporting policy. Communicate. Follow facility policy about who, when, and where the information is shared with the resident or family. Providers should communicate the facts of what happened and assure the patient and family that they will receive new information as it is discovered. It can sometimes be difficult for care providers to take ownership and communicate with the resident and/or family. However, prompt, compassionate, and honest communication following an event is essential. And remember, communication is an ongoing process that occurs from initial reporting of the incident through investigation and resolution. During the initial communication with the resident and family, providers should communicate only relevant facts that are reasonably certain at the time because further investigation and resolution may be necessary. Advise the resident and family that communication will be ongoing as follow-up investigation occurs. Advise the resident and family that a designated contact person, usually the nurse manager, is available for their questions and concerns. Document in the medical record the facts of the incident and any care the resident received as a result of the incident. The discussion with the resident and family should be documented by providers, and the documentation should include an objective description of the event, the resident's response to the event, and the care provided as a result of the event. When an incident occurs, the facility should investigate and analyze it. For example, conduct a root cause analysis to determine if resident harm occurred. When the facility determines that unreasonable care was provided, the following information should be communicated to the resident and family: an apology for any unreasonable care, an explanation of what happened, a meaningful discussion of projected outcomes, an early offer of remediation such as waiving bills and compensation. The facility should use information learned from the investigation to identify and implement system and process improvements. The facility should track, trend, and analyze event data for quality assurance and other identified purposes. The facility should also establish initial and continual training requirements for professional, administrative, and support staff. It is important to remember that residents and family members can experience a number of emotions when an adverse event occurs, so communication about an adverse event should be compassionate and sensitive. The care provider should speak slowly and use clear language. The provider should begin with an alert such as, "I'm afraid I have some news I need to share with you," and then provide the information in a few short sentences. The provider should wait for a response and listen carefully to any concerns shared by the resident and/or family. The facility should be prepared to address the concerns and, if committed to transparency, offer an apology that the incident happened. We have now reviewed the different tools to promote effective communication among staff, residents, and families. We have also discussed potential barriers and strategies to address communication challenges. The video shows how these tools come together in helping teams communicate more effectively to improve the care of residents.
Thank you for coming back to meet with us, Kathy. This is our nurse manager, Barry Woodman. I believe you've met before?
We have. Good morning, Ms. Matthews.
Good morning.
Ms. Matthews, can you tell Barry about your concerns with your mother?
Sure. My mother took a lot of pride in her appearance. If you'd known her before, She wouldn't have wanted to smell like this. And it can't be good for her. I didn't think that this was the kind of place that let people sit in their own pee.
And we're not, Miss Matthews. And I apologize that your mother wasn't cleaned up more quickly. I also want to let you know that the first thing I did after we spoke was to talk to the doctor to see if there was a medical reason for her incontinence. Unfortunately, there's nothing we can do to prevent it.
So why can't she have a catheter? My friend's mother, who's at a different nursing home, has one.
Well, catheters are very useful when they're medically necessary. For example, I know that your mother had a catheter last year when she was admitted to the hospital due to her condition. It's not a good idea to leave them in for a long period of time.
Why not? She needs one all the time.
Well, Miss Matthews, if we were to leave a catheter in your mother, she'd most likely get a urinary tract infection.
Infection? That would not be good, especially at her age. But aren't there antibiotics to treat infections?
Yes, but antibiotics have drawbacks. They kill both good and bad bacteria, which would make your mother susceptible to other infections that could give her symptoms like diarrhea.
Oh, that would be awful.
And there's also the danger of the bacteria becoming resistant to the antibiotics if they're taken when they're not necessary, which make infections harder to cure. We just don't like to use antibiotics if they're not necessary. And there's other problems with catheters. If your mother had a catheter in, it would be harder for her to move around, or she could pull on it, and that could be very painful, or it could cause her to trip and fall, and, well, we certainly don't want that to happen.
I appreciate that you're trying to keep my mother safe. But I can't sit here and tell you that I'm okay with her smelling the way she did. I mean, her whole room smelled terrible.
I agree, it did smell in her room.
Well, maybe we can try a more absorbent adult diaper, one that's going to ensure less leaking.
But I still want her changed whenever she's wet. I don't want her to go so long between changes.
Yes, you're absolutely right. We will change the schedule so she's checked more frequently. And I can see that you're still not comfortable. There's something else we can try.
What's that?
We can try and get your mother set up on a toileting schedule. We'll start by observing the times of day that she generally needs to go, and then we'll set up a schedule based on her routines.
But she doesn't always speak up when she needs to go. How will you know when she needs to go to the bathroom?
People can get used to going to the bathroom at certain times of the day. The nursing assistants will take your mother to the bathroom when she's used to going, and then it becomes a habit. Many of our residents, like your mom, have memory issues, but we've been successful at creating a toileting schedule that works for each of them.
Okay, but here's my concern. I trust that Lisa and Alexa will keep to the schedule, but they're not always here, and neither am I. What then?
Well, we appreciate your trust in them, and they're great members of our staff. But here's how it'll work. We'll write your mother's toileting schedule into her care plan. Every staff member who oversees her care will refer to that plan. They'll know when to take her to the toilet.
And Ms. Matthews, we have meetings during shift changes to ensure oncoming staff are aware of any changes in a resident's care plan.
Ms. Matthews, why don't we give it a try? We'll schedule a meeting in a few weeks so we can check back and make sure that your mother's new health care plan is working.
That sounds good. I really appreciate that. Thank you.
Of course.
Thank you.
We have covered many examples of effective communication skills and tools that can be used by nursing home staff and residents and families to improve teamwork and communication. You have heard about the TeamSTEPPS tools for long-term care facilities that staff can learn and use to enhance a culture of resident safety. The safety team involved in this program can use these tools and strategies to teach and evaluate staff communication and track improvements in resident safety.